wherein we will be discussing about introduction to cell injury and its consequences, and then different types of cellular adaptations, and then in detail about reversible cell injury and its morphological forms. So first we will see about introduction to cell injury. As such, if we see a normal cell, it will be in a steady state. That steady state of a cell is called as a homeostasis. That means there is a balance between its internal cellular environment and external environment. Okay, so based on these factors, a cell injury, it is defined as an effect of a variety of stresses due to etiological agents a cell encounters, resulting in changes in its internal as well as external environment. Like as I told you, this kind of disturbance in its internal and external environment because of variety of stresses, and those stresses because of different etiological agents that imposing upon a cell is called as cell injury. And if you take this flow chart here, here is a normal cell where it is in a steady state of homeostasis. So this normal cell, whenever it is under the any influence of stress, okay, if it is a mild stress, it will start to undergo adaptation, which is nothing but cellular adaptation, which is of different types, and it is a reversible change. Okay, so it can go back to a normal cell again. But if at all, if the cell is unable to adapt to this cellular adaptations, then it will undergo cell injury. So this cell injury, if at all the stimulus, the stress or the etiological agent, if it is mild or transient, then it will form a reversible cell injury where the cell can go back to normal state. That is, it can go back to a normal cell. But if at all that stimulus, okay, that etiological agent or the stress, if it is very severe and it is in a progressive manner, that means the intensity of the etiological agent is very high, then it will result in an irreversible injury. And this irreversible injury is nothing but cell death, which is in the form of either necrosis or apoptosis. In this present topic, we will be talking about cellular adaptations as well as reversible cell injury. Okay. So the next topic of discussion is cellular adaptations to stress. So cellular adaptations to stress, basically these changes, like I told before, they are reversible. That means if the stimulus is removed, they can go back to its normal state of homeostasis. And this reversible changes in the number, size, phenotype and metabolic activity or functions of the cell are termed as cellular adaptations. So these are reversible, and a cell can vary in its size and its number and its phenotype and its metabolic activity. Depending upon these factors, there are different types of adaptations like hypertrophy, hyperplasia, atrophy and metaplasia. Now let's see in detail about these cellular adaptations. First is hypertrophy. Hypertrophy means there is increase in the size of the cell. Okay, so this is a normal cell here, but this normal cell has a greater functional demand. But this cell, it is a non-dividing cell. That means it has a functional demand, but it cannot divide. Okay, what it can do is, like, to cope up with the functional demand, it can increase its structural proteins as well as organelles inside the cell. But how long can it increase? Like, as the cell size is very minimal, it cannot accommodate all the structural proteins and organelles. So it has to increase its size to accommodate all the structural proteins as well as organelles. So this kind of increase in size of a cell because of functional demand is called as hypertrophy, and sometimes it can be because of growth factor stimulation or it can be because of hormonal stimulation also. And this hypertrophy, it can occur because of some physiological causes as well as some pathological causes. So what are all the physiological causes of hypertrophy? Where all it can occur? So in pregnancy, because of under the influence of estrogen hormone, there can be smooth muscle hypertrophy which results in enlargement of the uterus. And also if you see in case of weightlifters, because they keep lifting the weight, because of which the muscle will undergo, that is the skeletal muscle of these biceps and triceps will undergo increase in size by the mechanism of hypertrophy only. So that is physiological cause. Whereas pathologically this hypertrophy is seen in cardiac muscle, where in cases like systemic hypertension, aortic valve disease or mitral insufficiency, in these three situations there will be cardiac muscle hypertrophy. And sometimes we even see hypertrophy of smooth muscle in case of cardiac achalasia, pyloric stenosis, intestinal strictures, as well as muscular arteries in hypertension. In these cases there will be hypertrophy of smooth muscle. And sometimes there will be compensatory hypertrophy. That means whenever compensatory, the name itself it is. So whenever one side, that is contralateral organ is removed, the remaining organ which is present, it will start to undergo increase in the size. That is called as compensatory hypertrophy, which can be seen in nephrectomy, where after the cutting off a kidney, the other kidney which is remaining, it will undergo increase in size. That is called as compensatory hypertrophy. Next adaptation is hyperplasia. Here what happens is there will be increase in the number of the cells. Okay, so here is one cell which is in a resting phase and it is a dividing cell. So because of the functional demand, it will start to divide and gives rise to more number of cells. So if we see, this is a cell cycle wherein G1, S, G2 and M phases are there. Okay, now because of functional demand, now our cell is in resting phase, that is G0 phase. So as functional demand is more, from G0 our cell will go into G1 phase and then it will undergo the whole cell cycle and undergo mitosis, that is cell division, and repeated cell divisions resulting in increased number of cells. So this is called as hyperplasia. So this hyperplasia can occur in only dividing cells, that is in labile cells and in stable cells, but not in permanent cells like neurons, cardiac and skeletal muscle cannot undergo hyperplasia. So even hyperplasia will have some physiological causes and pathological causes. So physiologic hyperplasia and pathologic hyperplasia. Physiological hyperplasia is seen because of hormonal influence. So hormonal hyperplasia, which can be seen in hyperplasia of pregnant uterus, as well as hyperplasia of female breast at puberty and during pregnancy, as well as during lactation. And sometimes proliferative activity of normal endometrium is also seen after a normal menstrual cycle, because during menstrual cycle there will be shedding of endometrium. So after the menstrual cycle is over, there will be again hyperplasia, dividing, endometrium will start to divide. So that is endometrial hyperplasia. And here also there is something called as compensatory hyperplasia, where if there is a any organ is cut off, then the remaining organ will regrow to the normal size, that is regeneration of a liver following partial hepatectomy. And sometimes whenever there is a skin abrasion or any wound, it will start to cover up or it will start to heal up by regeneration of the epidermis. So this is also compensatory hyperplasia or physiologic hyperplasia. Next, causes of pathological hyperplasia. So here endometrial hyperplasia can be seen following estrogen excess, and whenever there is stimulation by human papilloma virus, the epithelial cells can results in proliferation, giving rise to skin warts. And even in wound healing also there is proliferation of fibroblasts as well as endothelial cells, resulting in granulation tissue. So this is pathological hyperplasia. So next cellular adaptation is atrophy. So here in atrophy, this is an opposite of hyperplasia and hypertrophy, wherein here there will be decrease in the number as well as decrease in the size of the cell. So this is a normal cell size, wherein it will undergo decrease in size as well as decrease in the number. So this mechanism of atrophy, it is a combination of decreased protein synthesis and increased protein degradation. That means basically proteins has to decrease. So either synthesis of it has to be decreased, or whatever are there has to undergo degradation. So this degradation of proteins can be by ubiquitin proteasome pathway. So all this decreased protein synthesis and increased protein degradation results in decrease in the number and size of the cells. As the cellular size and number is decreased, obviously it will result in decrease in the size of the tissue or organ. And this atrophy is also it has both physiological causes and pathological causes, wherein physiological atrophy is seen in cases of aging, or it can be because of some loss of endocrine stimulation. So atrophy is seen in case of lymphoid tissue. With age, lymphoid tissue will undergo atrophy, and even thymus in adult life can undergo atrophy. And after menopause, there will be atrophy of gonads, we'll see. And with aging, there will be atrophy of the brain. That is why we start to lose our memory. Okay, so these are all physiological causes of atrophy. Next, pathological causes of atrophy. There are various causes. First is starvation atrophy. So in starvation, there will be depletion of both carbohydrates and fat stores, followed by protein catabolism, which will result in generalized weakness, cachexia and anemia of the body. Next is ischemic atrophy. Here there will be decreased blood supply. So this will result in the shrinkage of the affected organ. So that because of the decreased supply resulting in atrophy is called as ischemic atrophy. Next is disuse atrophy, where there will be prolonged diminished functional activity of the organ. So like if at all any limb, that is even upper or lower limbs, when they are immobilized in a cast for a very long time, there will be wasting of the muscles resulting in disuse atrophy. Even in neuropathic atrophy, there can be wasting of the muscles seen because of the interruption in nerve supply. So this interruption in nerve supply is seen in poliomyelitis, motor neuron disease and nerve sections. Next is endocrine atrophy, wherein because of the loss of endocrine stimulation, there will be decreased metabolic activity. As no metabolic activity, there will be no functioning of the organs, resulting in atrophy again. Next is pressure atrophy. So where sometimes because of some tumors or any cysts present in an area, so prolonged pressure from these tumors or cysts in that area can result in compression and lack of blood supply. That can result in atrophy of that particular tissue. So this is pressure atrophy. Now let's see about metaplasia. So it is one type of adaptation which is reversible, in which one adult cell type is replaced by another adult cell type. Okay, so it can be either epithelial or mesenchymal. So for example, if you see here in this picture, this is like a thing that it is the epithelium of a chronic smoker, that is a cigarette smoker, wherein his trachea or bronchi, they are lined by ciliated columnar epithelium. But because for chronic smoking, this columnar epithelium is replaced by stratified squamous epithelium. That is, it is undergoing squamous metaplasia, because squamous epithelium, it gives more protection to the trachea or bronchi. So it is an adaptation based upon the function, and this metaplasia can be seen in both epithelium as well as connective tissue. So first we'll see about epithelial metaplasia, wherein the commonest form of epithelial metaplasia is squamous metaplasia. So here so in bronchus we'll see squamous metaplasia, like I have given already that example. In case of chronic smokers, their normal pseudostratified columnar epithelium is changed to stratified squamous epithelium. Even in gallbladder, where in their ducts and everything, if at all there is a stone formation, caliculi formation, that is in case of chronic cholecystitis or cholelithiasis, their simple columnar epithelium is will undergo metaplasia to stratified squamous epithelium as a protective mechanism. And like in gallbladder, even in renal, pelvis and urinary bladder also, we often talk about kidney stones, right? So same way, in chronic infection and even in the presence of stones in renal pelvis, it will undergo squamous metaplasia. And this can occur even in salivary gland ducts, wherein silolithiasis is a condition where caliculi present in or stone present in the gland or duct of salivary glands, resulting in squamous metaplasia. So one more type of epithelial metaplasia is columnar metaplasia. Here other epithelial types are changed into columnar epithelium. So this is seen in case of intestinal metaplasia in healed chronic gastric ulcer, and even this columnar metaplasia is seen in Barrett's esophagus also. Normally esophagus is lined by squamous epithelium. So wherein in case of Barrett's esophagus, this normal squamous epithelium is changed to columnar epithelium. So this is an example of columnar metaplasia. Okay, so these are two variants of epithelial metaplasia. Now let's see about mesenchymal metaplasia. So here one type of mesenchymal tissue is changed to another type of mesenchymal tissue. Okay, so first example of it is osseous metaplasia. That is osseous in the sense formation of bone, right? So there will be formation of bone or osseous metaplasia in place of fibrous tissue, or in place of cartilage, or in place of myxoid tissue. So that is called as osseous metaplasia. So this is seen in case of myositis ossificans, wherein soft tissues in myositis ossificans undergoes osseous metaplasia. And in scars of chronic inflammation which are of prolonged duration, even there osseous metaplasia can occur. And even in arterial wall in old age, that is in case of Monckeberg's sclerosis, there also even osseous metaplasia will occur. So other than osseous metaplasia, there is cartilaginous metaplasia also, wherein because of decreased mobility in healing of the fractures in the limbs, okay, there can be cartilaginous metaplasia which can occur because of decreased mobility. So these are all various types of adaptations which are seen under stress. So next, if these adaptations are not healed properly, then results in cell injury. First of it is reversible cell injury. Okay, so reversible cell injury, it can occur because of various factors, like it can be physical, chemical agents, hormonal agents, genetic factors, many things, hypoxia and ischemia. The commonest factor is ischemia, which is lack of blood supply, resulting in decreased oxygen. So whenever there is decreased oxygen, this will result in mitochondrial damage. So mitochondria, it is a major organelle which helps in production of ATP by a process called as oxidative phosphorylation. As there is mitochondrial damage, there will be decreased oxidative phosphorylation which results in decreased ATP. So all this what we are discussing is a pathogenesis of reversible cell injury. So because of this decreased ATP, there are various consequences. First is decreased sodium pump. So what happens in sodium pump is that, so see, if you see this picture here, this is a sodium potassium pump, wherein the middle blue channel is there, right? That is sodium potassium ATPase channel, which is mediated by ATP. So this ATP, what it does is like, it will help in the movement of sodium towards exterior. That is, it will throw sodium outside and it will help in inward movement of potassium. So now in case of reversible cell injury, there will be decreased ATP. That means there will be more influx of sodium and efflux of potassium. That is, opposite will happen. So as you can see, decreased sodium pump, it results in increased influx of calcium, sodium and increased efflux of potassium. And whenever sodium is moving in, right, it will bring along water also. So as sodium is increasing in the cell more, and also it results in accumulation of water also more, that results in cellular swelling and loss of microvilli, and as well as organelles also, they will start to swell. Endoplasmic reticular swelling, cellular swelling, everything. So that is one consequence of decreased ATP. And as there is ischemia, that is and hypoxia, there will be increased anaerobic glycolysis because no oxygen, right? So what is the consequence of anaerobic glycolysis? It is lactic acid production, because aerobic glycolysis pyruvic acid is produced. Because of increased lactic acid, there will be decrease in pH, that is acidic environment will be more. As there is acidic environment, there will be changes in the nuclear chromatin, that is there will be clumping of nuclear chromatin which will be seen as a result of anaerobic glycolysis. And decreased ATP also results in detachment of the ribosomes. So basically these ribosomes, they are attached together, they help in protein synthesis. As there is detachment of the ribosomes, there will be decreased protein synthesis. So these are all various consequences seen in reversible cell injury. Okay, so if you see morphological forms of cell injury, reversible cell injury, they are of various types. That for the first one is hyaline change, hydropic change. First is hydropic change, next is hyaline change, followed by mucoid change and fatty change. So let's see each morphological form of reversible cell injury. First is hydropic change. So this hydropic change is also called as cellular swelling or cloudy swelling or vacuolar degeneration. Okay, cloudy swelling or vacuolar degeneration. So it is actually a consequence of decreased ATP and change in the sodium potassium ATPase pump, like we have discussed before. That is the main pathogenesis behind hydropic change. So if you see this flow chart here, there is decreased ATP. Okay, as we know, in reversible cell injury we have decreased ATP resulting in decreased activity of sodium potassium pump. That results in increased influx of sodium into the cell, which also brings water. That results in cellular swelling. If you see this microscopic picture and if you see these two cells, actually this is a picture of kidney tubular epithelial cells, wherein there is a normal tubule and a swollen tubule, hydropic change tubule. So wherein these tubular epithelial cells are swollen, and if you see there are vacuoles within these tubules, and as there is as these tubular cells are swollen, it results in compression of the blood capillaries. So the microvasculature is compressed between these tubular cells. Okay, these are all various changes which are seen in hydropic change. Next is hyaline change. So hyaline means what? It means glassy appearance. So here there will be glassy homogeneous eosinophilic appearance of proteinaceous material, which is seen upon H&D stained sections. So glassy homogeneous eosinophilic proteinaceous material is seen. So here is a microscopic picture. You can see that pink deposition there. All that pink deposition is nothing but hyaline change, which is seen in a muscle tumor. Okay, and this hyaline change can occur within the cell or outside the cell, that is intracellularly it can occur or extracellularly also it can occur. Okay, if you see intracellular hyaline, so where all this intracellular hyaline is seen, so it can be seen in renal tubular epithelial cells. Okay, because of excessive reabsorption of plasma proteins. So these are all renal tubular epithelial cells, and here and there you can see that pink deposition, right? That is all is nothing but intracellular hyaline within each epithelial cell. Okay, these kind of hyaline is called as hyaline droplets, which are seen in renal tubules. And the next one is hyaline degeneration, which is seen in rectus abdominalis muscle. So this is an abdominalis muscle wherein it is undergoing hyaline degeneration. This type of degeneration is called as Zenker's degeneration, that is seen in case of typhoid fever. Zenker's degeneration seen in rectus abdominalis muscle. And the next one is like whenever there is a hyaline change which occurs in liver cells. So these are all hepatocytes or liver cells. Where this change is occurring in alcoholic liver cell injury. Here there will be hyaline aggregates are seen, as you can as it is point there, pink deposition. This is nothing but Mallory's hyaline, okay, which is seen in alcoholic liver cell injury. And the next is, so these are all plasma proteins, okay. Excessive accumulation of immunoglobulins in these plasma cells results in hyaline change, okay. So all that pink deposition, right, within the cells, that is called as hyaline change, and these bodies are called as Russell's bodies, which are seen in plasma cells. And these kind of Russell bodies are seen in odontogenic cysts also when it is pertaining to oral cavity, okay. So next is extracellular hyaline. So this extracellular hyaline, that is outside in the extracellular matrix. So it is seen in case of leiomyomas, that is hyaline degeneration in leiomyomas, and in case of old scars of fibrocollagenous tissues, there will be hyalinization which can occur. And in arteriosclerosis in renal vessels, hyalinization can occur, and hyalinized glomeruli can be seen in glomerulonephritis. And in case of corpora amylacia, that is in prostrates of elderly, the hyalinization can be seen. So this is all is about hyaline change. The next reversible cell injury is mucoid change, wherein mucoid means mucus like material, wherein this mucus, it is a secretory product of mucus glands, okay. So it is a combination of both proteins and mucopolysaccharides. That means mucin, it is a glycoprotein, and this mucin, it is produced both by epithelial cells and connective tissue cells, and connective tissue also. In epithelial cells, like it is by mucous membranes and mucous glands, and in connective tissue, this mucin deposition is called as myxoid. So as we know, there is epithelial mucin now and connective tissue mucin. So where all this epithelial mucin is seen? So let's discuss about epithelial mucin. And this mucin, right, sometimes it will appear clear in appearance, so it can be stained by some special stains like Alcian blue and periodic acid shift stain, okay. So now let's see about epithelial mucin. So it is seen in case of catarrhal inflammation of mucous membrane or obstruction of the duct in oral cavity, that is in case of mucocele or ranula, wherein there will be extravasation of the mucin which is seen. And then cystic fibrosis of pancreas, and also epithelial mucin seen in mucus secreting tumors of ovary or large bowel, etc. Okay, so this is all is where epithelial mucin is seen. Now where is connective tissue mucin seen? Connective tissue mucin, it is seen in case of some mucoid or myxoid, seen as mucoid or myxoid change in some tumors like myxomas. Even in oral cavity, odontogenic myxomas can occur, and sometimes in dissecting aneurysm of aorta, and even in case of thyroid conditions like myxedema, where there is a myxomatous change. And sometimes this myxoid change can be seen in synovium, in ganglion on the wrist. So these are all where connective tissue mucin is seen. So this is about mucoid change. Now let's talk about the last of reversible cell injury, that is fatty change. So fatty change, so it is also called as steatosis, and actually it is mainly it is seen as appearance of lipid vacuoles within the cytoplasm of any cell. Okay, so lipid vacuoles will be appeared. That means it is like intracellular accumulation of neutral fat within parenchymal cells. And actually this kind of fatty change, right, it is principally seen in cells which participate in fatty metabolism. So fat metabolism, what all the cells will be participating? That is liver cells, that is hepatocytes, as well as myocardial cells. These are the ones which will participate in fat metabolism, and this is a place where there can be fatty change which can occur. And in hepatocytes, that is liver, if that change occurs, it is called as fatty liver also. So this is about reversible cell injury and its morphological forms. And to conclude, Like we have discussed about cell injury and its consequences, that is like how a cell can undergo cellular adaptations, then cell injury in the form of reversible and irreversible changes. And we have even discussed about different types of cellular adaptations, and then we discussed about reversible cell injury and some of the pathogenesis of reversible cell injury and its various morphological forms.